Meningitis is an acute inflammation of the meninges and the fluid surrounding the spinal cord and brain of the patient. We can categorize meningitis into two categories: bacterial meningitis and viral meningitis. Bacterial meningitis has become a public health concern around the world, with different causes based on age and geographical location. The number of people with meningitis worldwide reached 10.6 million in 2017, resulting in 288,000 deaths, compared with 464,000 deaths in 1990. If properly treated, bacterial meningitis has a mortality rate of less than 15%. Three of the most common causative pathogens of bacterial meningitis are Streptococcus pneumonia, Neisseria meningitidis, and Haemophilus influenza. Meningeal pathogens can reach the leptomeninges through the bloodstream. The pathogens that colonize the epithelium of the meninges first colonize the respiratory tract, gastrointestinal tract, or lower genital tract. There are a variety of invasins and hissins expressed by meningeal pathogens, allowing them to attach to and cross the endothelium of the brain. The attachment of meningeal pathogens, for example as pneumonia, to endothelial cells occurs through the interaction between selected surface molecules and their 67-kDa laminin receptor. Interactions between bacteria and endothelium facilitate transcellular passage of pneumonia. The bacteria may also release toxins called hydrogen dioxide and pneumolysine, which can disrupt the endothelial monolayer, allowing them to cross the blood-brain barrier or the blood-cerebrospinal fluid barrier via a paracellular pathway.
The introduction of vaccines dramatically reduces the incidence of meningitis by providing enhanced serotype-specific T-cell-mediated immunity. The efficacy of vaccinations, however, is limited to the included serotypes, and the emergence of non-vaccine and non-typable serotypes limits their efficacy. Incidence of bacterial meningitis and the responsible serotypes vary widely, both geographically and over time. In areas prone to specific serotypes, vaccine targeting different serotypes would be implemented to reduce the incidence. Symptoms of bacterial meningitis most commonly include neck stiffness, fever, and altered mental status, which are known as the classic triad of meningitis. In accordance with the European Society for Clinical Microbiology and Infectious Disease guidelines, bacterial meningitis should be treated at least within 1 hour after presenting. Initial antimicrobial therapy is selected based on the most common bacteria that causes meningitis, the patient's age, and the local antimicrobial susceptibility patterns are taken into consideration as well. Then, after the causative pathogen is identified and the antimicrobial susceptibility patterns of bacteria are determined, the therapy has to be optimized. According to several cohort studies, adjunctive dexamethasone therapy has improved outcomes of bacterial meningitis in several countries. Therefore, the use of dexamethasone is sometimes recommended in patients with bacterial meningitis beyond neonatal age. In recent decades, some strains of bacteria has developed resistance to penicillin and cephalosporins, changing the initial treatment for patients with bacterial meningitis in several countries. Moreover, the replacement of causative pathogens by non-vaccine serotypes has been reported in several countries, demonstrating that meningitis continues to be a serious health concern. That's to say, it is essential for us to come up with new approaches to develop efficient prophylactic and therapeutic strategies for meningitis in the future.